All right, good morning. Yeah, let's close the door, please. Thank you. Today is March 28th, and this is Senate Health and Welfare. We've had a long week, and we're continuing our work now, looking at two bills that have come to us from the House, and the two this morning are from House Human Services. So Representative Noyes, thank you for being here. And I think you know everyone around the table, do you?
I'm not sure that I've met Senator Hart.
Senator Hart, Orange County.
Nice to meet you.
And you know Senator Douglas?
Yep.
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 Senator Dooley?
Yep.
Senator Cummings will be in a minute.
Wonderful.
All right, so thank you for bringing us H13. Why don't we,
Sure.
just give us the overview, Jen will walk through that section
Yeah.
by section with us. It'd be great.
Very easy. All right. For the record, Dan Noyes from Wolcott, representative from Wolcott, Hyde Park, Johnson, and Belvidere. So H13 is a rate study that asks the Secretary of Human Services to determine reasonable and adequate rates for home and community-based provider, designated agencies, specialized service agencies. Essentially, this is a rate study to provide Medicaid services and supports to older Vermonters and individuals with disabilities. We've talked about this bill for many years. We've done portions of these home and community-based providers, but this really tries to look at bigger picture on what it costs to deliver these services here in Vermont. And as we look forward into what may be ahead with limited resources, it's going to be important to know actually what it costs to deliver these services, because we're going to have to make some potentially hard decisions on our funding decisions. So having the actual costs, I think, are going to be really helpful in determining where different agencies stand in terms of what we're funding to build those, to provide those services to essentially Vermont's most vulnerable. So the agencies include home health agencies, residential care, enhanced residential care, adult day providers, assisted community care services. Those are under the home and community base. The specialized service agencies and designated agencies, it also looks at the rates there. So the DAs, there's 11 designated agencies. There are examples: Memorial County Mental Health, Rutland Mental Health Services, Howard Center, and the SSAs, or specialized service agencies. There's 7 in our state for individuals with developmental disabilities or intellectual disabilities and provide mental health services. Green Mountain Support Services, Champlain Community Services, Family First, and Southern Vermont are some examples of these agencies. So H13 acknowledges that there's limited revenue acknowledges revenue limitations, to say that fast, for these providers to be able to for funding. So in 23, we had a rate study that was in the budget that found that HCCS was underfunded by 79%, leading to
What's HCCS?
Assisted Community Care Services.
And where is that? And what is
Those are residential care. Yeah, and so we had underfunded those, and just trying to bring those up. And we saw, actually I have some numbers here on so there was residential care homes. There was a net loss of 321 residential care beds since 2020. 23 facilities had closed and only 5 had opened. So this is just from historical underfunding. We're losing access to these services for older Vermonters, which ends up shifting to our more costly care, nursing homes. If we can kind of reach upstream and have these services available for individuals that are less cost, And just by knowing what they cost, we can try to figure out how to fund them with the money that we have. We saw in the budget adjustment, 24 million for skilled nursing facilities to cover increased utilization just this year, and 21 million for emergency financial relief. So if we can make strategic investments in these home and community-based providers, we may be able to reduce some of those costs moving forward.
Sounds like efficiencies, waste, efficiencies, yeah.
So basically, this bill, ask them to do this rate study and then provide updates so that we get a report back knowing what it costs, so that as we're working on our budgets, we have a better idea of where we are in relationship, especially for our joint fiscal office to know what these costs are, so they can tell us what we funded them in the past and, what the needs are moving forward. So I'll just go through the sections of the bill real quick. Section 1, definition, funding sources, eligibility criteria for home and community-based services. Section 2, Secretary Agency, Human Services to determine adequate reimbursement rates, state and federal mandates, cost of goods and services, inflation, labor market pressures, geographic differences, annual inflation adjustments, and emergency relief. Oh, and it also tries to come up with a way to provide emergency financial relief, what that might look for other home and community-based providers, so that maybe if they get to a point where they need additional resources to keep the door open, because we all know that like adult day providers, we lost a few of them during COVID. It's really hard to stand them back up once they've closed. So if there's a possible way we could provide them with some finances to keep open, then we're not going to have to try to stand them back up until they close. Section 3, same methodology for conducting the rate study for the designated and specialized service agencies. And then section 4, is a report back to the legislature on January 15th. And the bill takes effect on passage. Our committee vote was 11-0-0. And there is a fiscal note that you should have. If you want. And there's no fiscal. They were able to do it within, they were able to calculate these rates. I don't know if you want to have Nolan talk to that, or if you want.
Probably.
It's posted on your website.
Yeah, we got it.
In actuality, in the House, this bill was sent to appropriations. Because there was a discussion that it may have costs, but with the fiscal note, they were able to say that there was no cost, and they put it right back on the floor. So it's kind of gone through House appropriations with not because it needed to, just because they thought there might be some cost to it.
Doesn't hurt.
Mm-hmm. Anyone has any questions?
For Representative Noyes. That was good. That was clear. And you have some good data in there that we may or may not get when we take testimony, but someone might be coming back to you. The reporter of the bill might be coming back to you.
Absolutely.
Support. That'd be great.
Mm-hmm.
Thank you for your work on this.
No problem.
I know. So, and the conversation extended to choices for care and SASH and all the things that we have. And then did it get into Meals on Wheels, AAAs? Did we get into that? Is that also included in that discussion?
So, no.
Okay. It's okay.
These are more of these specific residential care, home health.
Okay.
Enhanced residential care, adult day providers, and ACCS.
Right. You can't do everything all at once.
Correct. Mm-hmm.
No. Okay. Any questions? Good. Okay.
Explain it all.
All right.
All right.
Thank you.
Thank you for your time.
I
I know, right? I ran in here today because, anyways, hiked in here from up on Liberty Street.
Oh,
Had run up to committee and we had an amendment up there and then back down. So thanks.
well, good work.
Take care.
Thank you.
Bye-bye.
Have a nice
Okay.
Good morning. Jen Harvey from the Office of Legislative Counsel. So I will put this as passed by the House bill up on the screen. Oh, good. All right, so we are looking at H13, an act relating to Medicaid payment rates for home and community-based service providers. Starts out with a new definition added to definition section in Title 33. This is on the chapter on rate setting, which is currently largely nursing home rate setting, but this would add an additional definition for home and community-based services, which we then use as a term later in the chapter. So in this case, the definition of home and community-based services is broader than just what is considered under the choices for care component of our section 1115 waiver. So it's a lot of other Medicaid supported services. And so this definition says the term means the following services provided pursuant to our global commitment waiver, or successor program, but it's not limited to just the choices for care definition of home and community-based services. So it means long-term services and supports provided to older adults and adults with disabilities in a home or community setting other than a nursing home, including enhanced residential care services. It includes home health and hospice services, adult day rehabilitation services, and assistive community care services, and short and long-term services and supports provided to individuals with mental conditions, individuals with substance use disorders, individuals with developmental or intellectual disabilities, and individuals with brain injury in a home or community setting for which the Medicaid rates are not otherwise established pursuant to statute or rule. We're really talking, in addition to choices for care, we're talking additional home health and hospice services and services from the typically provided by the designated and specialized service agencies. So it had been kind of written more focusing on providers and as introduced, and it was shifted more to providers of the types of services rather than the types of providers themselves. Section 2 adds the new section in the same chapter. So the section for which that definition would apply, payment rates for providers of home and community-based services. And this directs the Secretary of Human Services to determine payment rates for those providers that are reasonable and adequate to achieve the required outcomes for the populations they serve. When determining the payment rates, requires the Secretary to adjust the rate amounts to take into account factors that include the cost of any governmental mandate that has been enacted, adopted, or imposed by any state or federal authority. So some of the things they're required, these providers to be required by law to comply with what the reasonable cost of that is. And a cost adjustment factor to reflect changes in reasonable costs of goods to and services of providers of home and community-based services, including those attributed to inflation and labor market dynamics. It also allows the Secretary, when determining these rates, to consider geographic differences in wages, benefits, housing, and real estate costs in each region of the state. Then it directs the Secretary to establish a methodology for determining the rates in accordance with this section, and says that the methodology must provide a schedule for conducting studies of the Medicaid reimbursement rates paid to providers of home and community-based services, including the rates adequacy and their underlying methodologies that include studying the rates paid to providers for each type of service at least once every 5 years. So continuing to kind of update and keep these current, but
Sounds like a
recognizing.
rolling learning plan.
I'm not familiar with that, but there is, it would have them continuing, AHS continuing to do rate studies for different providers
Right.
over time, so that we're continuing to keep those fairly current, but recognizing they don't have the capacity to do every group every year.
Yeah.
It would set forth a predictable timeline for redetermination of base rates, include a process for determining an annual inflationary rate adjustment, to the extent permitted by the Centers for Medicare and Medicaid Services, take into account the financial needs of providers whose reimbursements may be negatively affected by client absences. So things like an adult day center that may only be reimbursed when somebody actually shows, even though they need to have the staffing available all the time. And use Vermont labor market rates and Vermont costs of operation. And then subsection D is the language Representative Noyes was talking about, having the secretary establish a process by which a provider whose financial condition places it at imminent risk of closure may seek extraordinary financial relief from the agency, something that exists for nursing homes in rural, and this would have a process created for these providers of home and community-based services. And then in subsection E, this is really sort of where what all this work leads to, is that the secretary will redetermine the payment rates for providers of home and community-based services in accordance with the section at least annually, and report those rates and the amounts necessary to fund them to committees of jurisdiction. So in House, that's House Appropriations, Human Services and Healthcare, and in the Senate, it's Appropriations and this committee annually as part of the agency's budget presentations. It's having a lot of information and kind of updated information provided to the legislature, so the legislature can make the decision about what to appropriate, but it does not actually obligate the funds unless and until legislature does so. Section 3 amends an existing statute in Title 18 on the rates of payments to the designated and specialized service agencies. And mostly what it does is just says, go look at this other statute that incorporates them into that larger group of women community-based service providers. Under the existing statute, the Secretary of Human Services has sole responsibility for establishing the Department of Health, Department of Mental Health, and Department of Disability, Aging and Independent Living's rates of payments for the designated and specialized service agencies. It uses a lot of the same language that's incorporated into that new section. So originally in the bill as introduced, there were kind of parallel provisions, one for most of what we were traditionally think of as home and community-based services in the long-term care context, and then parallel language here for the designated and specialized service agencies. House Human Services combined those into one section in Title 33, and so now this language just points over to that section. But importantly, the language in the existing statute gives the Secretary of Human Services sole responsibility for establishing, but does not actually require the establishment. And so there's been some difference of opinion or expectation about whether these rates for the DAs and SSAs should have been being determined or established on an ongoing basis, but that has not happened. And so this is making that more actionable, at least to have that information provided to the legislature to make decisions. Section 4 is the update report. So this would have on or before January 15th of 2026, the Agency of Human Services reporting to this committee and to the House Healthcare and House Human Services, an update of the agency's implementation of that section, that new section in Section 2, including the agency's proposed schedule for Medicaid rate studies and the methodology that the agency developed for determining payment rates for providers of home and community-based services. So that would be an update on how the actual work is going, not just the piece they're supposed to come with their budget presentation and tell you how much. And the act will take effect on passage.
Okay. I have some questions. So this is only regarding the rates and the rate setting for these residential and other services. So
Right, not residential necessarily, they're home and community based,
Yeah.
right? So it's not nursing homes, not facilities for which we have other rate
so
setting.
not nursing homes.
Not nursing
What
homes,
is
not
not in
hospital,
here?
not nursing homes, not hospitals, not PNMIs.
Okay, and everybody knows what PNMI is, right?
Can we say?
Private non-medical
It's-
institutions.
Right. So not
What's an
nursing
example?
homes,
What's an example?
not hospitals,
I don't remember what the PNMI.
and
Who, no, but who is it? Like, what is it?
Oh, God.
We don't.
Wait,
talk about
16
them.
beds or more when you have someone. with a-
That's different.
Well, it's an institution for,
So this is not an institution for mental disease.
No.
This is a private, non-medical institution. I think
Right.
it's for, are there folks in the room? who know
and it
this?
can't be bigger than
I like
16 beds.
Okay,
All right, no, so that's okay. We don't really define it because it's not in.
right. There is separate rate setting that exists in the Agency of Human Services for that. I'm just gonna share so I can look stuff up.
Not nursing homes, not PNMIs.
Right.
There anything else that we should be excluding in our heads? Just so we don't think about the wrong.
I don't think so. I mean, it's not major
Uh-huh.
medical. We're not talking about doctor's offices.
Right.
We're really more on the human services side of,
Caring for people as they
Of
get
caring
older
for
and need
people.
some support
right.
in home or in
Right,
residential.
but also, I mean, also mental health care, substance use disorder treatment. I mean, it is,
Does it include recovery residents?
some of this will need to,
We don't know.
some of this
So
I'll
we
need to defer to
find out.
the Agency of Human Services.
Yes, we want to know if it includes recovery residents.
Seven CM up there, that's awesome.
Yeah,
Right,
there.
right.
Well,
I
I
think-
want to get this in our little heads so that we don't,
Right.
yeah.
So generally for most of these, they're not residential. They may be residential like residential care homes, but they're not institutional residential.
They don't have medical
Thank you.
services.
So the PNMI programs, and providers in Vermont, there's Brookhaven Children and Family Services in Chelsea, Community House in Brattleboro. The Howard Center is listed, although obviously they do other
That's a
things as
separate
well.
part of Howard Center.
Lund Family Center,
Yeah.
NFI Vermont, Retreat. But I don't know, some of these may have programs as part of their,
Right.
PNMI programs as part of their services.
Right.
Steel
Just one
implemented
chunk
in
of something.
Bennington, Vermont Permanency Initiative in Bennington and Windsor County Youth Services. And I think you would hear from.
We'll hear from
AHS folks and others about what services those provide.
We want clarity on that, actually, so. And then, what else do we need? It's not, we want to know that's not. We know we're kind of, we're gonna sort out what is.
Okay, here, this is helpful.
Oh.
I just looked up on DEVA's website, private non-medical institutions for residential childcare is PNMI. The state funds a network of treatment facilities for children and adolescents with emotional behavior and other challenges through PNMI for residential childcare. And the Division of Rate Setting already sets their rates as they do for the nursing homes.
Okay, so we can take them out of the
There's-
equation.
Yes.
This could get really confusing if you tried to explain it all on the floor. So we're trying, we want to separate out what it isn't, so we don't.
Right, I mean,
The wrong
these, so,
place.
sort of in
Like,
a
that's
nutshell,
like-
these are providers for whom there are not already rate setting methodologies established. So there's not, in statute, you direct nursing home rate setting. They do, I'm not sure if it's specifically required, but as part of that, they do the PNMI rate setting. But for a lot of the rest of these, there's not sort of a directive to do rate setting. I mean, AHS does establish rates because they pay these providers, but there isn't the same sort of methodology established that I'm aware of for these providers for their Medicaid rates. So that's what this is establishing.
Okay. I have another question. Okay, so as the bill was being discussed in the House Human Services, was there any discussion about how all of this is going to fit with contractual relationships with these entities?
In what sense?
Well, I mean, when you're there, it feels like there might want to be some administrative consolidation, oversight, efficiency put in place with all of this. I don't know if that was a conversation. And the contracts that go out with each organization. Now we're gonna have uniform rate setting. Was there any discussion about a more uniform contractual criteria or anything like that? I don't want to bring it up
There
necessarily.
was not I don't believe there was discussion about sort of contractual terms other than,
Just the rate
Rates.
setting. Okay.
and I don't know what the contracts literally look like and the extent to which.
I mean, we've looked at some of the contracts in the past and there's some complexity involved to those and also some reporting that adds complexity. So maybe someday we'll look at those.
This was very focused on determination of payment rates.
Yeah, okay.
And it's really, I think the methodologies, it's the methodology that becomes standardized. The rates themselves don't necessarily, because they're supposed to take into account some of the localized demand in the area, labor shortages,
Okay.
et cetera.
Have any questions for Jen on this? Would you have time? So,
Madam Chair,
yes,
can I just say one
joint fiscal.
thing about, it's in my fiscal note, and I don't need to testify, but just want to make it
For
clear.
the record,
For the record, Noel and I will joint fiscal office. This requires AHS to determine what the rate should be. It does not require them to actually implement and increase the rates.
right,
That's why there's no fiscal note. If
yeah,
it actually had automatic, then it would have a very big fiscal note.
okay,
So I just wanted to make that clear, that just because they're doing it, study and determining rates and going through the process, they don't actually have to increase the rates.
but the fact that it's coming in before, in the middle of, what, is it February or January?
Well, the rates will be reported, or the sort of proposed rates will be reported as part of the budget presentations annually. So you're getting an update on the development of the methodology in January.
That's it,
But then the annual reporting of the agency has done the calculations, and these would be the rates, and here's what it would cost to fund them, will be part of the budget process. And I will also just clarify and kind of, tacking on to Nola's point, I believe a good part of the reason the bill was sent to the Appropriations Committee is because it has the potential for appropriations or for fiscal demands in the future. So it was important for appropriations to be aware that this information would be incoming, and there would likely be requests and perhaps in some sectors expectations that funds would be allocated accordingly.
okay. So, so the report's coming in January, theoretically, they could get some information during the budget preparation process in the fall and have it in there, then this would back up whatever decisions they make if they did that. Right, okay. All right. What I was going to ask is if you would mind going through again, very briefly, what's here in the bill to offer us some clarity, and then we'll take a little break.
All right, so in the bill, again, in section 1, it is adding a definition, is kind of cleaning up the lead-in language on lines 7 and 8. So to me, that's more technical, just to be consistent with our definition sections. But it's adding a definition for purposes of this chapter on rate setting for home and community-based services. And it's a list of services that are provided through the Global Commitment Program. So we have long-term services and supports provided to older adults and adults with disabilities in a home or community setting other than a nursing home, including enhanced residential care services. We have home, health, and hospice services, adult day rehabilitation services, and assistive community care services, and short and long-term services and supports provided to individuals with mental conditions, individuals with substance use disorders, individuals with developmental or intellectual disabilities, and individuals with a brain injury in a home or community setting for which the Medicaid rates are not otherwise established pursuant to statute or rule. Section 2 is the requirement that the Secretary of Human Services determine rates for these providers that are reasonable and adequate to achieve the required outcomes for the populations they serve, and directs the Secretary to adjust the rates to take into account factors including reasonable costs of governmental mandates and cost adjustment factors reflecting reasonable costs, changes in reasonable costs of goods and services for these providers, including those due to inflation and labor market dynamics. Also allows the Secretary to consider geographic differences in wages, benefits, housing, and real estate costs in different parts of the state. Directs the Secretary to establish a methodology for determining the payment rates that has a schedule for doing rate studies. And that includes studying the rates for each type of providers of each type of service at least once every 5 years. Includes a predictable timeline for redetermining base rates. Includes a process for determining an annual inflationary rate adjustment. Looks at the financial needs of providers whose reimbursements may be negatively affected by client absences. So those are that are attendance based, to the extent the federal government allows us to consider that, and use Vermont data, Vermont labor market rates, and Vermont costs of operation. It has the Secretary establishing a process for a provider to seek extraordinary financial relief if its financial condition places it at imminent risk of closure. And then requires the Secretary to do the redeterminations at least annually and report the rates and the amounts necessary to fund them, which really is the legislative decision there, to the committees of jurisdiction annually as part of the agency's budget presentation. Section 3 is updating an existing statute on rates and payments to designated and specialized services agencies to just point to continue to have a reference in the statute or the chapter on DAs and SSAs to payment rates, but says that the payment rates will be determined in accordance with that new section we just looked at in section 2. Section 4, as the Agency of Human Services reporting to the legislature by January 15th with an update on how they're implementing that new section 2. Including their proposed schedule for rate studies and the methodology that they have developed. And to expect on it.
Okay. Good. So now we have an understanding what's in here, what's not in here, and that it's a report on rate setting to begin to look at those things that don't have a formal rate setting process currently.
Right. And my understanding is a large part of the kind of rationale for the bill is that you hear every year from all these various providers about the rate increases they are requesting. And this would allow you to have the Agency of Human Services view of what would be an appropriate rate. And then you can make informed decisions based on.
Well, there's good news and there's bad news with that last comment. I mean, the good news is that it'll make our work more efficient. The bad news is we won't be seeing everybody.
I think you'll still be seeing. If you can rest assured, you'll still be seeing.
I'm surprised it's already being done. Honestly.
Yeah, no, these are the kinds of things that evolve over time, and it's not foreseen that you're going to have the need that exists out in the state. So, yeah. So thank you, Jen. And before we take a break, I see folks in the room who would like to perhaps testify on the bill. And if you do want to do that, I see you shaking your heads, just like Kiki know. And actually, if you could right now, if you'd like to raise your hand and offer a quick comment on the extent of your comments, do you have more to add that you would like us to include in the bill, or is the bill perfect for you, or just those kinds of comments would be helpful, just so understanding of what we need to hear about. So I'm looking at Amy. I know.
I think that I will have some good comments during testimony to be able to add. But we are supportive of the bill.
All right. Who else? No.
Helen Laban, Vermont Healthcare Association. My comments, should I offer them, will be short and supportive. We think this bill is great and important and very timely. To the observation that we are surprised that it isn't already happening.
All right, good. All right. Matt,
And Matt Levin, Vermont Coalition on that, the Alliance, we're discussing the possibility of including children's and trade services into the bill. Although we want to do a little more homework to make sure that it can be done in a simple way and it wouldn't cause complications because we understand the importance or the underlying bill. So
yeah,
we would like to get a chance to testify, but in the meantime, we're doing some investigation.
okay, good. All right,
We don't want to disrupt progress here, but
good thing.
in potentially adding that as a.
That's good.
as
That's
issue.
helpful. All right, anything else? We're good. All right, so thank you for that. And I'm thinking, unless I'm thinking wrong, I'm thinking that you are the folks who have the greatest interest in here. Well, we'll see who else is interested in. That's
And
fine.
I should have glanced around the room first before I spoke to see if there were other members of the Long-Term Care Crisis Coalition here. So there is a broader coalition that's supportive of this bill and has been from the beginning, of which Vermont Healthcare Association is a member. I believe you have Molly from Cathedral Square testifying at some point. She often speaks on behalf of that coalition.
Thank you. All right. Okay, good. So we'll take a break and we'll be back at 10.